Welcome everybody to tonight's webinar. I'd like to begin by acknowledging the traditional owners and custodians of the land and waterways from which we are all zooming in from today. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations people and organisers who will work together on closing the gap. So welcome again. My name is Helene and alongside me is Jade, and we are the Workforce Development Officers at the PHN. So welcome to our Women's Health webinar series, Period Issues Tonight. A little bit of housekeeping. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. Jade will put the link across and access to that recorded webinar into the chat. We have a practice communique that we send out to practices fortnightly with valuable information, including an internal and external calendar of events. You can also subscribe to the Westvic PHN fortnightly newsletter via our webinar. For this evening's meeting, may I ask participants to remain on mute for the course, and should you have any questions, please type them in the questions box and I will address them at the end of the talk. They will be addressed anonymously, so just pop them all in there and we'll get them answered for you. Our speaker for this evening is Dr. Vidhu Krishnan, who's Obstetrician Gynaecologist who works alongside Dr. Marilla Druitt in Geelong. You'll notice in your handout section that there's an introduction letter about the Dr. Vidhu, and it'll outline her qualifications and where she's working and stuff like that, as well as her details if you need to contact her. So welcome Vidhu, and I will now hand over to you.
Thank you for this opportunity. I'm just gonna share my screen. Can anybody see my screen?
Hi Vidhu, it's Jade from the PHN. If you just bring your presentation up and then remember on the other screen, you need to put it in presenter mode. So if you go slideshow and start presentation.
Sure, sorry.
Great, and just go up to display perfect swap.
Cool, can you see? All right, excellent, thank you. All right, cool. Thank you for this opportunity for making this presentation. As Helene has mentioned, I'm currently working with Dr. Druitt in her rooms, as well as I'm one of the new consultants who's joined in University Hospital in Geelong. So talking about period problems, what I'm hoping that we do achieve by this talk is we know what are the common menstrual problems that patients would come to us in the clinic, but what we are hoping to achieve by the end of this talk is that we can also identify the cause for these common problems and thereby come up with put in place appropriate investigations, and thereby it will help us guide the management for solving the problems that the patients are coming with. And based on that, we would find out if the treatment is working, not working, and therefore we get an idea when it will be appropriate for us to actually refer the patients, or so that the patients are sorted. The most common problems that patients do present with, I think, and this is my reference from Better Health channel in Victoria, the most common problems is painful periods, or dysmenorrhea as we know them, heavy periods, absent periods, and premenstrual syndrome. As I mentioned previously, period problems is quite a broad term, so I have used the most common problems that we do encounter, and I've selected these 4 problems that might present to you in your rooms. I just wanted to also acknowledge the great work that general practitioners do. Menstrual problems itself is quite traumatic for the patients, and they do not usually come straight to us specialists. So as general practitioners, you are the first people that the patients come seeking help, and it's such an important role that the patients, where by the time they come to us, they are aware of the problems, they are aware of the treatments that can be done for them, and it makes our lives so much easier. So thank you again for the great work that you are all doing. Coming to the first most common problem, dysmenorrhea. Now, as most of the problems, if we cannot identify a cause for it, we label them as primary, and that's what primary dysmenorrhea is. There's no cause identified as such. The secondary dysmenorrhea is when there's a specific cause that is present. I will explore the various causes for secondary dysmenorrhea a little later in the talk. What I have done is kind of classified dysmenorrhea according to the age groups. So first I'm addressing the problems that a young adult would come to you with. The most common problem that adolescents have when they have dysmenorrhea, it is almost 16 to 90% of the time it is primary in nature. There have been several studies that severe menstrual pain is associated with absenteeism from school and work, as well as limitation of other daily activities. Around 1/3 to 1/2 of the females with primary dysmenorrhea are missing school or work at least once per cycle, and sometimes more frequently than what is reported. One should also be mindful that 70% of these group of patients self-medicate. They always have a friend, a mother, or somebody that they know that will advise them as to what they can take. Therefore, it's quite difficult to establish the accurate prevalence of dysmenorrhea. Also, primarily because there's a variety of diagnostic criteria and also the subjective nature of the symptoms that the patients present with. Like I mentioned, 90% of the time it is primary dysmenorrhea, but in 10% of the cases, the patients in the young adults, they do have secondary causes for it. The most classical symptoms of primary dysmenorrhea is that it usually begins within 2 years of menarche, starts right before menstruation or at the time of menstruation. Most commonly, it is a lower abdominal pain that can radiate to the back, and it usually never really lasts more than 72 hours. And most of the time, they are associated with additional symptoms such as nausea, vomiting, dizziness. These are what I say the classical symptoms, but there can be other variations as well. Now, what is the cause for primary dysmenorrhea? We're still figuring, like I mentioned before, we're still figuring out what it could be caused due to. But what they have found is that the prostaglandin levels are almost 4 times higher in patients with dysmenorrhea as compared to those who do not have it. It's very important. This particular thing is very important because it kind of guides us the management. If we know that prostaglandins are the cause for the pain, we would know that antiprostaglandins would help in the management of this pain. And that's why pathophysiology for primary dysmenorrhea is important. In terms of evaluation and management, it's very, very, very important history. And it is very important, especially in a young patient, that we also find out about if there are any other aspects in her medical history that would suggest that the dysmenorrhea is actually secondary in nature. One of the other things that, especially in young adults, that I find difficult is that they are sometimes really scared. They do not talk. They do not talk much in presence of their parents. And sometimes there can be history of associated symptoms that we would want to get from them, which is probably not a great idea to get it in front of the parent that is usually accompanying them. Usually what I do is when the patient walks in the room, I usually ask the patient if she's comfortable enough that I can ask her some questions in her mother's absence. And I also do take permission from the mother before actually asking the questions that can be kind of sensitive for the patient and the family as such. I would be interested in knowing what my other fellow practitioners do when they do have a young adult coming into their rooms. Hopefully we can discuss it at the end of the talk. The other things that I wanted to mention, that when they do come in with primary dysmenorrhea, one should ask them about the age, the menstrual pattern, onset and character of menstrual symptoms, if they have been sexually active, also to get an idea about how the dysmenorrhea is actually affecting the patient in her quality of life, whether she's had her school performance affected, school, work, absenteeism, and also any family history of menstrual disorders. Things that can help us in their medical history, which will give us an idea that it's probably not primary dysmenorrhea, is if the onset of dysmenorrhea is associated with some heavy menstrual bleeding, there is intermenstrual bleeding, postcoital bleeding, or if there's a sudden change in the pattern of the period. Usually, secondary dysmenorrhea is more commonly seen in the third decade or later, although it might also be present since the onset of menstruation. So those are the things in the medical history that can be helpful when the patient first presents to us. Most of the patients, like I mentioned, especially young patients, they would have already tried some kind of pain relief. So if they've already tried some analgesics like Nurofen or naproxen, and there has been a poor response to almost a 3 month of the regular analgesics that they have taken, then it should definitely make us suspicious of secondary dysmenorrhea. Also, if they have any other history of suggestive of endometriosis, if we have even the slightest suspicion that there is a possibility of a secondary dysmenorrhea, then I would definitely look at organizing an ultrasound. Pelvic examinations are something, especially in young adults, that can be tricky. So one should always offer a patient a pelvic examination. If there is something in her history that is suggestive of secondary dysmenorrhea and the patient is also sexually active, definitely a pelvic examination is something that should be offered, as well as in patients that have symptoms that are suggestive of endometriosis. Even a rectal examination can be offered, because things such as thickness of the uterosacrals, nodularity of the uterosacrals that are seen, it could be suggestive of deep-seated endometriosis. Let's just go to the next slide, sorry. One of the other things I did want to mention is if you do encounter young patients who are smoking, then it's a good idea to have a discussion about quitting smoking, since smoking is associated with prolonged dysmenorrhea symptoms. In addition, if there is also some evidence that consumption of fish such as salmon, tuna, mackerel, and herring, which are very rich in long-chain omega-3 polyunsaturated fatty acids, is known to be of benefit in treating dysmenorrhea. So those are simple things in terms of lifestyle which can be advised to the patients to help in management of their condition. Okay. Looking at the treatment part of, oh sorry, just missed a slide. Looking at the treatment part, Many of the patients, because they are young patients, they would prefer to have, at least some of them at least would like to have a trial of what we say a non-pharmacological management for their dysmenorrhea. There is some evidence that TENS machine is of benefit. It's definitely of benefit as compared to a placebo. There is insufficient evidence to recommend low frequency TENS machine, but a meta-analysis of high frequency TENS machine has shown that it is definitely superior to placebo, and high frequency TENS nerve stimulation is helpful in 30% of the cases in women with severe dysmenorrhea, and they require lower doses of NSAIDs to manage the pain in their cycle. There has also been studies that acupuncture and acupressure is of benefit. There are no like specific schedule that one can recommend in terms of acupuncture, and treatments have ranged from once per menstrual cycle to daily for 7 days. Recommendations were to use acupuncture for 1 minute at least twice daily, or up to 5 times per day, because it's, I mean, I've been advised that there are some general practitioners who do have acupuncture and acupressure services in their unit, and it can be sometimes bulk billed. So I think it is something that can definitely be considered, because I just think that it is one of the things that is easily available. It would work kind of well in a patient's schedule, although one does need large randomized control trials to better understand the potential benefit, but it can be definitely used in addition to the conventional pharmacotherapy that we have in place. Continuous heat applied to the suprapubic region does provide relief of pain for some women, but we do need high quality trials to actually confirm its efficacy. Exercise and yoga, there have been multiple studies that it is definitely known to be of benefit. One of the pathways that it works through is by increasing the blood flow, endorphin release, and lowering stress and anxiety. There was a Cochrane review exploring the effect of exercise on primary dysmenorrhea, and they did find that exercise decreased symptoms of dysmenorrhea, and this improvement was sustained over 3 menstrual cycles. There is an excellent website of the Pelvic Pain Foundation that does have the stretches that one can use, which is, I think, applicable not only for chronic pelvic pain, but also for patients who have dysmenorrhea. And we use it quite frequently in rooms as handouts for the patients to take home. It gives a clear description of the kind of stretches that the patients can follow. And I think it's definitely an excellent resource that I can recommend for everybody. In terms of the analgesics or the medications that one can use, NSAIDs are definitely the first line. It's a preferred initial treatment, and it should be tried for at least 3 menstrual periods before we can say it's not working. The treatment, the NSAIDs that are recommended in the therapeutic guidelines are ibuprofen, naproxen, and mefenamic acid. And I think they're quite easily available, and most of the patients, by the time they come to see us in the specialist rooms, have already had a go with it. It is most effective when it is started at least 1 to 2 days before the onset of menstruation. Adolescents who cannot predict the initiation of the period should be instructed to start them as soon as the menstrual bleeding begins, or as soon as they have any menstrual associated symptoms. It is important to provide the young adults specific instructions about the dose and the maximum daily frequency of the recommended medication. If one preparation does not provide relief, a second NSAIDs can be used. They should be Usually the dysmenorrhea resolves by day 2 or day 3 of the menstrual period, and a short course of the treatment does limit the development of the side effects that they can experience with the use of these medications. If the treatment with the NSAIDs is not effective, then a combination pill can be offered. And it's the same principle. We offer it for a period of at least 3 menstrual cycles. It is, I do have another slide that does discuss in detail about the use of pills. I'm just not going to go in detail at this point, but I will definitely discuss it at the end of all the slides. So what we did find is that the pill, an extended use of the pill is better than using it cyclically. So what I mean by that is having a continuous use of the period without a break is definitely better than using what we say 21 days and then the pill free or the sugar free pills. So they can just skip the pill and use it continuously for 3 months, and it's definitely preferred. Progesterone only pills as is also can definitely be offered. They are especially in those group of patients who cannot use estrogen for some reasons. They remain options because they do inhibit ovulation and eliminate menstrual cycles. Depot, progesterone only contraceptive pills, and Mirena or levonorgestrel intrauterine device, they likely improve the symptoms through this mechanism. Approximately 50% of patients who are on Depot and 20% of patients who are on Mirena are amenorrheic by the end of 1 year of use. So it's for these group of patients, it would be helpful. If the patient is quite young, we can definitely offer to put the Mirena in theaters under general anesthetic. The other IUD, Kylina, which is available, which is the lower dose of the progesterone, it is recommended only for contraceptive use. It doesn't have, what do you say, kind of use in terms of management of period pain or heavy menstrual bleeding. When you find that the dysmenorrhea has not responded to NSAIDs or combined pill that has been given for at least 3 menstrual cycles, it should raise suspicion of secondary dysmenorrhea. Now, looking at secondary dysmenorrhea, in adolescents, the most common cause is endometriosis. Although the true prevalence of endometriosis in adolescents is not known, at least 2/3 of adolescent girls with chronic pelvic pain or dysmenorrhea, unresponsive to hormonal therapies and NSAIDs, will be diagnosed with endometriosis at the time of diagnostic laparoscopy. If they are under 17, there is, or even above, Ranscock has just released, or maybe last year, Ranscock has released guidelines for management of endometriosis. And there is a rate questionnaire. It's easily available on the website. This rate questionnaire has got specific questions that look at the patient's pain. And I think it's an excellent guide for the patients to fill out this questionnaire before they approach a healthcare worker. So it's one of the resources that the patient can use, and it can also give us as the primary carer an idea of where this patient's pain or how it is actually affecting the patient. Like I mentioned before, if there is a suspicion of secondary dysmenorrhea in young adults, pelvic imaging, regardless of the findings of pelvic examination, should definitely be considered. Any obstructive anomaly of the reproductive tract, whether hymenal, vaginal, or Mullerian, can cause secondary dysmenorrhea. Even if there is a suspicion of secondary dysmenorrhea, besides the investigations as an initial treatment, definitely NSAIDs should be considered. And as we are working up the patients further, a treatment specific to the cause can be then formulated. One should ideally avoid prescribing narcotics long-term to young patients for management of their pain outside of a specialized pain management team. So definitely consider NSAIDs, but look at avoiding narcotics. Now, looking at secondary dysmenorrhea in general, not just adolescents, endometriosis still is the most common cause. And while evaluating the patient in terms of the history, the things that one needs to be mindful when it is endometriosis is that it can be cyclic with menstruation, and it's usually associated with deep dyspareunia, dysuria, dyschezia, and subfertility. These symptoms are indicative of involvement of other organs, like dyschezia, involvement of the bowels, dysuria, there could be involvement of the bladder, and even if in conditions of deep dyspareunia, it can be indicative that the ovaries are quite stuck and widespread adhesions. A rectovaginal examination is helpful. It can identify fixed or retroverted uterus or reduced uterine mobility, adnexal masses, and uterosacral nodularity. If there is a suspicion that this patient who has presented to your rooms has deep endometriosis, one of the investigations that one can refer the patient for is a DIE scan or a deep infiltrating scan, which can be helpful in planning the surgery for the patient, because most of the time, if the patient has deep-seated endometriosis, laparoscopy would be planned for. And also, management of such group of patients is best in a multidisciplinary team. These patients have extensive effect of endometriosis on their lifestyle, so they require a lot of help, and definitely I would recommend referring these group of patients to a specific endometriosis team, or at least to a gynecologist who is specialized in management of endometriosis. Pelvic inflammatory disease is another, what I would say, an extremely common and annoying problem that we continue to see in our group of patients, especially those who are sexually active. The most common problems continue to be in terms of pelvic inflammatory disease. It is still most commonly caused by gonorrhea and chlamydia, and it is something that one should be mindful of in any group of patients who are sexually active. A scan in patients with PID is generally not helpful, and it's most clinical diagnosis. One can do a saline microscopy of the vaginal fluid, might show the organism, and definitely most of the time we can make a clinical diagnosis based on what the patient is giving as a history as well as our examination finding. Looking at adenomyosis, it is usually associated with heavy menstrual bleeding, and it might include intermenstrual bleeding. Examination finds, we can definitely find an enlarged, tender, boggy uterus. An ultrasound nowadays is quite helpful, and most of the ultrasounds are quite effective, and they can give us an clue that this patient probably has got adenomyosis. And there are specific features in the ultrasound that can detect adenomyosis. Combined treatment, usually a trial of hormones might be helpful, but most of the time these patients, when they are referred to specialist care, especially if they are completed their family, they do most likely end up having a hysterectomy. Besides gynecological problem, the other things that one can think about when a patient comes with secondary dysmenorrhea is looking at interstitial cystitis. They typically have a history of non-cyclic suprapubic pain, and it is associated with urinary symptoms. The pain can radiate into the groin and the rectum, and it's usually relieved by voiding. The important clue in this group of patients is that they will have negative pelvic examination findings. Things like urine analysis might give us a clue. and also a referral to a urologist would be helpful, as a cystoscopy usually ends up showing the irritation of the bladder wall mucosa. Of course, chronic pelvic pain, it's become an endemic, I think, nowadays. It's a history of non-cyclic pelvic pain present for at least 6 months. The patient does need to have this particular pain present for 6 months before they actually get referred to any kind of chronic pain team. And it's very non-specific pain. It can radiate anteriorly towards the vagina, posteriorly towards the rectum. It's usually worsened by anxiety, and the patients have dyspareunia and difficulty with defecation. It's most of the time, chronic pelvic pain and endometriosis are kind of linked, and you would find that patients who come to you with symptoms that are clinical features suggestive of endometriosis usually have an element of chronic pelvic pain as well. Although I need to stress again the importance of the great Pelvic Pain Foundation website. Like I mentioned, it does cover a lot of things that can cause chronic pelvic pain, not just gynecological symptoms, but things like irritable bowel syndrome, patients who have got really tense pelvic muscles. And it does give us these group of patients, like I mentioned, require management in a multidisciplinary team. One of the things that can help the group of patients is referred to a pelvic floor physio who can help in training this group of individuals in relaxation of the pelvic floor muscles. We do have a physio that comes to the rooms who specifically deals with pelvic floor muscle relaxation. There is definitely great evidence that pelvic floor muscle relaxation in these group of patients is of benefit, but it has to be followed for a period of time, not just one-off, and usually a time frame of around 3 months is something that is known to show benefit for them. Just touching upon pelvic inflammatory disease again, like I mentioned before, it is something that we do need to consider on patients who are sexually active. And as I mentioned, chlamydia and gonorrhea are still the most common causes that we encounter. However, there can be other cervical, enteric, bacterial vaginosis associated, and even respiratory pathogens such as tuberculosis that may be involved. It is something that I think tuberculosis more so in group of patients, especially migrants and refugees who do present to your clinic, definitely do consider that as a differential diagnosis. Pelvic inflammatory disease can be acute, chronic, or subclinical, and is often underdiagnosed. It's a really important condition because if it's untreated, it can lead to chronic pelvic pain, infertility, and intra-abdominal infections. Like I mentioned before, the diagnosis is made primarily on clinical suspicion, and empiric treatment is definitely recommended in sexually active young women or women at risk for sexually transmitted infections who have unexplained lower abdominal or pelvic pain and cervical motion, uterine or adnexal tenderness on examination. Mild to moderate disease can be easily treated in an outpatient setting. It is something that we see quite commonly in our emergency department, and it's such an easy, the treatment of this condition can be done so easily, and it is a shame when patients come to us with infertility and long-term chronic pelvic pain secondary to this condition. I think it's very important that we do diagnose these conditions early and put in place appropriate treatment plans just to avoid the patients from suffering the sequelae of this condition in the long term. Now, touching the other problem that can be what is commonly seen in the rooms is heavy periods. or heavy menstrual bleeding, or menorrhagia as it was previously known. It's defined as like when a patient has a blood loss of more than 80 mils in a cycle, but it's quite hard to predict actually how much is 80 mils, and most of the times we have a subjective idea of how the patient is actually, how much the patient is actually bleeding. Usually they might present with, give us a history of flooding, which is a change of pad or tampon more frequently. Palm-Cohen is a classification that FIGO has come up with, and it helps in the classification with palm referring to the structural problems, polyp, adenomyosis, leiomyoma, malignancy, or hyperplasia, and Cohen referring to non-structural etiologies, which is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. Just as in patients who present with dysmenorrhea, history is really, really important. The things that covers that one can cover in the history includes the nature of the bleeding, if she's got any other related symptoms such as persistent intermenstrual bleeding, pelvic pain, pressure symptoms that might actually suggest a uterine cavity abnormality, histological abnormality, adenomyosis, or fibroids. One should also, when taking the history, get an idea about the impact on her quality of life, and also other factors that might affect her treatment options, such as the kind of treatment she's previously had for heavy menstrual bleeding, or whether she has other comorbidities. If the NICE guidelines mentions that if the woman has a history of heavy menstrual bleeding and there are no other related symptoms, then one can initiate pharmacological treatment without carrying out a physical examination. I just find it a bit hard. I think any patient who comes to you with symptoms which is heavy menstrual bleeding, I would definitely offer the patient a physical examination. There are so many things that one can pick up just by examining the woman. If the woman chooses not to, that's a different thing, but definitely offer the patient a physical examination. One can pick up so many things. I mean, if she's got a palpable uterus, it's quite significant, and it might suggest you that she's actually got a big fibroid. And it would help us definitely in guiding any further investigations that we need to do. Definitely carry out a full blood count test for all women with heavy menstrual bleeding in parallel with any other treatment that one is offering them. In case if in the history there is a suggestion that there is a possibility of fibroids or uterine cavity abnormality or adenomyosis, definitely organize a pelvic ultrasound. In all honesty, if there is a suspicion of heavy periods, I think I would definitely recommend organizing a pelvic ultrasound. It gives us a lot of information, and it does give us an idea whether one needs to refer the patient for a specialist, or it is something a specialist, or even if she requires urgent surgery. So definitely a pelvic ultrasound is, I would recommend as one of the investigation tools. Now, in young adults, the most common cause that we see when they present with heavy menstrual bleeding is ovulatory dysfunction. Anovulation is more commonly seen, and it's mainly due to a lack of a functional corpus luteum. There is absence of progesterone and a relative excess of estrogen acting on the endometrium. It is this imbalance that leads to excessive and uncontrolled bleeding. Their hypothalamic, pituitary, and ovarian axis is also immature, and one should be always mindful that it is a diagnosis of exclusion. And so one should always think of other causes as well that can cause a young patient to have heavy periods. But definitely it is the most common cause that happens, and it is most commonly seen in the first 2 to 3 years after they first start having their periods. Ovulatory dysfunction also can be caused by a number of other endocrinological abnormalities, which includes a thyroid disease, hyperprolactinemia, polycystic ovarian syndrome, as well as obesity. So this is something that should be considered in young adults while one is doing their diagnostic workup. Always be mindful to make sure that the patient is not pregnant. In terms of, in around 20% of the cases, heavy periods can be secondary to bleeding disorders. And in the most common one, or 1% of the cases, it is the von Willebrand deficiency that is responsible for the patient having heavy periods. Just like I cannot stress how important it is in patients who present with period problems to take the history. One of the things that one should always evaluate for is, things, especially in patients who have heavy menstrual bleeding, one should always check for confidential issues such as sexual activity, potentially sexual transmitted infection, exposure, sexual trauma, and it's definitely recommended that it should be conducted with the adolescent alone. Usually a shared decision making with the patient's family, while just taking the history, and even while planning out the management for the young adults. If there is any other endocrinological or bleeding symptoms that are identified in the history, then we should definitely look at organizing, most commonly, the thyroid function test, including, as well as, like I mentioned, a full blood count. That one can definitely pick up things like thrombocytopenia that could be a cause for the heavy menstrual bleeding that the patients might be experiencing. As I mentioned before, heavy menstrual bleeding is quite difficult because to assess in terms of subjective symptoms. One of the things that is commonly used is a pictorial blood loss assessment chart. I'll just bring the chart up. And this can be something that we use in our rooms as well. And it is something that the patient can easily tell us if the patient has losing too much blood, and it gives us an idea how much of a blood loss that she's having. A score more than 100 is quite, there have been a number of studies that have shown us that scores more than 100 is definitely indicative that the patient is having heavy menstrual loss. Just going back to the previous slide, like I mentioned, the basic tests that one does need to organize for patients with heavy menstrual bleeding include a full blood count, ferritin, and a pregnancy test. An ultrasound will easily pick up any kind of structural abnormalities, although it is accountable only for a small minority of cases of heavy menstrual bleeding in adolescents. It is more sensitive in detection of large masses, clinically significant Müllerian abnormalities, and therefore it will help us guide in referring this patient for a specialist care. Just another slide wherein one can, if a patient has, if there is a suspicion of coagulopathy as a cause of a heavy menstrual bleeding. So some of the symptoms that the patients can present with is things like she's got epistaxis that lasts for more than 10 minutes, bleeding from the gums, cutaneous bleeding that are lasting for more than 10 minutes, but from small lacerations or abrasions, muscle or joint bleeding. In the history, if there is anything suspicious of coagulopathy, then definitely consideration for organizing of further blood tests, as well as referral to a hematology team. Now, another review again. So that was a specific test that I was considering when looking at young adults, but looking at the other group, if other group of patients, if they present with heavy menstrual bleeding, the basic investigations that one needs to consider is a full blood count, ferritin again, if any history suggestive of coagulation disorders or thyroid issues, then consider organizing coagulation studies as well as thyroid function test. A cervical smear test is definitely something that I would organize in the age group of more than 25, or any other history that is suggestive of risk for cervical cancer. Ultrasounds, like I mentioned, they are helpful if there is a suspicion of fibroids, polyps, or if the patients have increased risk of cancer. Therapeutic guidelines has got a great flow chart that definitely helps in guiding us in terms of the investigations that need to be ordered, as well as in terms of planning out the treatment. Patients, in terms of acute management, if the patient is hemodynamically stable and the anemia is not severe, wherein if the HB is between more than 80 but less than 120, then one can definitely consider an outpatient management with iron supplementation as well as hormones. As the slide mentions, I have put in the various treatment regimes that one can follow in. Any combined oral contraceptive pill can be used. There is a lack of randomized clinical trials comparing the efficacy of different combinations of the combined oral pills, and they've essentially found that most of the combined pills are really effective. Those with very low ethinyl estradiol dosages, that is 10 microgram, are more likely associated with breakthrough bleeding. Therefore, it's generally better to avoid using such ultra low doses of estrogen dose for management of heavy menstrual bleeding. As I mentioned before, Kalina is primarily for contraception and it is not for heavy menstrual bleeding. In adolescent group as well, Mirena is definitely superior to other hormonal methods in its effect on heavy menstrual bleeding, and it is well tolerated in adolescents. As I mentioned before, in younger group of patients, it is a bit more uncomfortable as compared to what I would say the older age group, but it is definitely that is something that can be considered, and we can consider putting it under general anesthetic, light or light sedation, and there is no minimum age limit that it can be tried on. In terms of long-term kind of management for this group of patients, Mirena definitely is much better method of management of heavy menstrual bleeding. It trumps the use of the combined pill, cyclical progesterone, as well as the hemostatic therapies. There have been a number of studies that have compared Mirena with the combined pill and found that the decrease in the menstrual blood loss was significantly greater. The most common reason that patients are not happy with the Mirena is its irregular spotting, hormonal tenderness, hormonal symptoms like breast tenderness, and abdominal and pelvic pain. And that's also the most common reason that they discontinue it within 5 years. In terms of the hormonal side effects, what we can counsel the patient is these symptoms do resolve by 6 months of use. When one does consider Mirena for the group of patients, it is really important the pre-counseling that happens before the insertion of Mirena. The counseling that needs to be happening is that the patients need to be told, for Mirena to work, you have to be patient. If you were bleeding for maybe 20 days in a month prior to insertion of Mirena, post Mirena, in the next 3 months, you would find that instead of 20 days, you would bleed only for 10 days. The 3 months post that you might bleed only for 5 days. The 3 months post that you might bleed only for like 2 days. So it is really, really important that their counseling has to be good. And if the counseling is good and the woman is aware the kind of side effects and the unscheduled bleeding that she might experience, they found that the continuation rate for Mirena is as much as 70%. It is definitely greatly reduced the number of hysterectomies that we do, but the key is the counseling, and once they're counseled properly, most of the women are really happy with it. The combined pill, it is definitely of benefit in young group of women and adolescents who are sometimes not really happy to have things inserted in their body. And there are a lot of there is a lot of studies that definitely show that use of the pill is effective. It's just how good the patients are in taking them. Just like with the Mirena, it's the hormonal side effects like breast tenderness, headache, mood changes, and depression that cause the patients not to use it. Similar to that of dysmenorrhea is the extended and the continued use is one that is of benefit rather than using it in a cyclical manner. Now, cyclical oral progesterones, they found that using it as a short term is not great. It is not really effective in reducing the menstrual blood loss. However, using it for 3 weeks, 3 weeks in a cycle is definitely known to be of benefit. Most commonly, it's if you're using a medroxyprogesterone, then the dose is around 5 to 10 milligram, and you use it on days 1 to 21. And if it's norethistron, then you use a 5 milligram dose 2 to 3 times daily from day 5 to day 26. One has to review the choice of therapy at in 6 months time and see how it is working for the patient. Patients, like we have a lot of group of patients who do come to our clinic and they're really happy to be just on progesterone, and it helps them control their cycle, and they're really happy with it. So it just definitely depends on the patient. If the patient is happy to be on it, it has made her life easier, then it is one of the options that can definitely be considered. Another agent that we commonly use for heavy menstrual bleeding is tranexamic acid. It's an antifibrinolytic agent, and it has definitely shown to significantly reduce the menstrual blood loss in women with heavy menstrual bleeding. However, the important thing to remember is that it does not reduce the duration of the menses, or it regulates the cycle. So there was a systematic review that found that the menstrual blood loss reduction, it came down to as much as 56%, and it has also a better reduction in the menstrual blood loss when it is used over 3 cycles. It is also effective. It can also be used in the initial periods when you use it with the Mirena to reduce the breakthrough bleeding that or the irregular bleeding patterns that the patients have with Mirena. So tranexamic acid is definitely one of a good medication to try, and all the studies, most of the studies did not specifically show an increase of any thromboembolic side effect or event as that occurred with the use of tranexamic acid. And tranexamic acid, when used in combination with NSAIDs, is definitely, especially in the younger group of patients, it can definitely be tried, and it is known to be of benefit. So when do we need to refer the patient? So definitely refer the patient if you tried a treatment and it has not worked for 6 months. One can also consider early referral to a patient before 6 months if she has got concurrent severe dysmenorrhea as a baseline. If she's got severe dysmenorrhea that has not settled despite 3 months of pharmacotherapy. There are patients who want to conceive and in whom fertility may be at risk, like endometriosis or adenomyosis is suspected. if there's fibroids which are greater than 3 centimeters, endometrial polyps, or there are symptoms that are suggestive of increased risk of endometrial cancer due to risk factors such as oligomenorrhea, polycystic ovary syndrome. If there's a personal or a family history of endometrial or colon cancer, when the patient is on unopposed estrogen, tamoxifen, she's obese, she's more than 45 years of age, or there is ultrasound findings, especially in premenopausal individuals where the endometrial thickness is more than 12 millimeters, or in perimenopausal individuals when it's more than 5 millimeters. So those are indications that these patients need to be referred as soon as possible for specialist care. So you tried all the patient has gone to a specialist, she's tried all the medical management, it's not worked, and she's sick of it. So the next option is when we consider looking at a surgical option. Surgical option, like I mentioned, she's tried everything, she's tried the medical management, it's not worked, it's made her life miserable, and she's just sick of it. So the things that we can definitely offer is endometrial ablation. So it's frequently used as an alternative to hysterectomy. They are minimally invasive, they have shorter operating time, recovery period, and is associated with fewer complications. The thing that one should be mindful of when one is recommending an endometrial ablation is that it's probably best when they are in the age group or in the perimenopausal age group, because it does have a failure rate. It's very important that the patient has completed her family. It's definitely something that we do not offer patients who are thinking of fertility options. And there is also, one should advise the patient that usually she would not have a complete amenorrhea, but hypomenorrhea. A bleeding pattern would significantly reduce following an endometrial ablation. But there is also a risk that she might require further surgery for treatment failure. The next option is the definitive management, which is hysterectomy. As everybody is aware, it is a major surgical procedure. It does carry serious risk of morbidity and death, and it's very important when a decision for a hysterectomy is made, the patient is fully aware of the risks associated with it. Having said that, however, it has become quite a common procedure, and it is something that is, I would say, done routinely and is done quite effectively. Although the rates of hysterectomy have definitely fallen because of things like endometrial ablation, availability of Mirena, but I would say the major operative complication rate is only 3%. And we have got such experts now that it is quite a safe procedure, but it is still, I mean, the patient does require appropriate counseling before she decides to go for that kind of pathway. Now, coming to the premenstrual syndrome, these are essentially psychiatric or somatic symptoms that develop within the luteal phase of the menstrual cycle, and it is something that affects the patient's normal daily functioning. But the important thing about PMS is that it does resolve shortly after menstruation. There are definitions that ACOG has put regarding premenstrual syndrome, and when they have to satisfy they should have at least one effective symptom and one somatic symptom that can cause a dysfunction in the patient's social, academic, or work performance before they can say that she's got a premenstrual syndrome. And these symptoms can be cyclical, and they must be cyclical. They begin after ovulation and resolve shortly after the onset of menstruation. About 80% of the women report at least one physical or psychiatric symptom during their luteal phase of the menstrual cycle. However, most do not report a significant impairment in their daily life. And therefore, we have got really poor understanding of the actual cause for this condition. There are several studies that suggest that the cyclical changes in the estrogen and the progesterone levels are the one that actually trigger off the patient to have PMS. Postmenopausal who have previously been diagnosed with PMS have had recurrent psychiatric and physical symptoms when they receive cyclical progesterone. And there have also been studies which show that suppression of estrogen with GnRH analogs have been known to improve the PMS symptoms. And that's why it's believed that it's probably the estrogen and the progesterone levels that trigger off these symptoms. The important thing to remember about PMS is that it's the timing. It's very, very important that the patients, the symptoms occur during the luteal phase and they resolve shortly after the onset of menstruation. Other conditions that one needs to be mindful of before saying that the patient has PMS is it can also mimic conditions like depression, anxiety, but they can be distinguished from PMS because they persist throughout the menstrual cycle. Conditions like migraines, anemia, endometriosis, and hypothyroidism may produce symptoms which are similar to PMS and PMD, premenstrual dysphoric disorder, and they should also be considered. If the patient has really significant symptoms and one is doubtful that it is actually a premenstrual syndrome, then a diagnostic laparoscopy can also be directed at ruling out alternative diagnoses. The treatment of premenstrual syndrome focuses on relieving both the physical and the psychiatric symptoms. Many of the medications used address the body's hormonal activity through suppression of ovulation, whereas others affect the concentration of neurotransmitters such as serotonin, norepinephrine, or dopamine in the brain. SSRIs are the first line of treatment for severe symptoms of PMS. Medications like Zoloft, paroxetine, Prozac, citalopram, escitalopram, they can be used and they're definitely known to be of benefit. They've had statistically significant benefits on patient-reported symptoms when they are taken continuously or only during the luteal phase. They can, all of the SSRI doses are effective for psychiatric symptoms and they should be ultimately titrated for patients' tolerability. The second group of drugs is the SNRIs. SNRIs such as venlafaxine has been used in patients with PMS primarily for the psychological symptoms, and the effect is achieved relatively over a short period, 3 to 4 weeks, and it has been sustained through the subsequent menstrual cycle. Now, Seroquel, this medication is also studied as adjunctive treatment with an SSRI or SNRI, and the goal was to improve luteal phase mood in women who did not respond to SSRI or SNRI therapies. There have been studies which showed that the pill has been of benefit while treating physical and psychiatric symptoms. And even as in other menstrual problems, one does recommend using a continuous rather than a cyclical dose of the medication. Other complementary medications that have been used include saffron, St. John's wort, ginkgo, but we do need more kind of studies before saying that, okay, these agents are helpful, and they're not definitely something that I would recommend as first line. Other patients, it has been known of benefit like exercise, yoga, cognitive benefit therapy are definitely other kind of management plans that can be tried, but in terms of evidence for it, it is something that we still are working on it, and therefore it can be recommended as something that can be tried along with the medications, but not as the first line. Now, looking at the last one of our period problems, it is amenorrhea or absent periods. As I mentioned before, when we do not know the cause for it, it's a primary amenorrhea. Primary amenorrhea is defined as absence of menses, and it requires evaluation if menarche has not occurred by 15 years of age or 3 years post-TILAC, that is breast development. Secondary amenorrhea is characterized by cessation of previously regular menses for 3 months or previously irregular menses for 6 months, and it also needs to be investigated. One should be mindful that all causes of secondary amenorrhea can present as primary amenorrhea, and the evaluation remains similar. The most important cause, I think, for amenorrhea that one does need to rule out is pregnancy. So please never ever forget this cause for amenorrhea. There can be a number of reasons where a patient can present with amenorrhea. Looking at it, I think Up-to-Date has got a really great plan or a chart looking at the causes for amenorrhea. It can be causes, as I mentioned, there can be a number of causes which include, and the etiologies can be characterized as outflow tract abnormalities, primary ovarian insufficiency, hypothalamic or pituitary disorders, other endocrine disorders such as hyperprolactinemia, thyroid disorders. It can be a sequelae of chronic disease where she might be diabetic, may have conditions like tuberculosis that one needs to be mindful as a cause for primary amenorrhea, or it can be just physiological or what we say induced amenorrhea. Physical examination is definitely the first step that one needs to do when a patient presents to you with not having had her periods. One should review her trends in height, weight, body mass index, whether there is normal breast development. Normal breast development indicates that there is presence of circulating estrogen. If the mucosa looks atrophic, it is indicative of a low estrogen. A shortened vagina may be indicative of outflow tract obstruction or Mullerian agenesis. When there are signs of virilization, it does suggest that there is possibility of a hyperandrogenic condition. And things, when you see evidence of dysmorphism, it suggests a congenital syndrome. I stress again, the most important thing in patients with amenorrhea is pregnancy should be excluded. The initial investigations that is of benefit is pregnancy test, assessment of serum follicle stimulating hormone, luteinizing hormone, prolactin, and thyroid stimulating thyroid stimulating hormone levels. Additional testing such as karyotyping, serum androgen evaluation, or pelvic and brain imaging should be individualized. Most of the endocrine abnormalities would be picked up by ordering these basic investigations. If the treatment should address the underlying cause. If there is a suspicion that the patient has polycystic ovarian syndrome, she should definitely undergo screening and intervention to attenuate the metabolic disease. If there is any suspicion of any outflow tract or any abnormal reproductive anatomy, a pelvic ultrasound is one of the first line investigations that will help us to assess the structure and also pick up any concerns that would need an early referral. Like I mentioned before, the treatment depends on the cause. And if it's a primary amenorrhea, I would aim at looking at an early referral. Any medications, there are a lot of medications that can cause hypothalamic or pituitary suppression or even hyperprolactinemia. And it's very important to review any medications that the patient might be on, and if possible to use an alternative medication. One of the other things that one needs to consider in patients with amenorrhea is their bone health. In patients with, especially in patients with prolonged secondary amenorrhea, usually one does start the patients on hormone therapy, and the estrogen therapy partially addresses this effect of long-term estrogen deficiency on the bone mineral density. And in patients who got functional hypothalamic amenorrhea, the correction of their energy imbalance with weight gain and improved nutrition is something that is required to help in their bone recovery. Patients who got secondary amenorrhea are found to have increased cardiovascular risk, and that is another thing that needs to be considered and evaluated when these group of patients present to you. As I mentioned before, I do a choice of the pill. Now, I can probably look at opening it for discussion in terms of, I just wanted to get an idea as to what our audience is healthcare professionals. If a patient presents with dysmenorrhea or heavy menstrual bleeding, is there any
We can't hear you. Did you mute yourself?
what I could do to aid the discussion is probably put a slide of the pill that is available in the market. And if, I don't know if the audience wants to speak or they want to type out, if they can give me an idea as to what is the most common or what is their choice of the pill and what makes them direct this particular choice. Is anybody responded? I can't hear you, Helen.
Sorry, we might have to finish up. It's 10 minutes over our scheduled time. I do have 2 questions that have come in. If you'd like me to read those out, and you can answer them before we finish up.
Yeah, sure.
First question: does Slinda help in patients with dysmenorrhea?
It is known to be of benefit. Yes, definitely. I can probably Slinda is definitely helpful. What in all the evidence or the literature that I have read in preparation for this particular topic, what I have found is that there is no specific pill. You can use anything that the choice of the pill is kind of determined by how well tolerated it is, if it's affordable, and what the patient is comfortable using it, and it's got like the side effect profile is acceptable to the patient. So you can definitely try Slinda. You can definitely try any pill that has worked well for you.
Next question: why would you choose QI?
QI, I'm not sure what is QI.
Why would you choose? I'll wait until. Why would you choose QLAIRA? QLAIRA.
It just depends. I mean, you mean, is it Clara? Is it the pill that, is that what you're talking about? Oh, you can use it for, like, it's a pill. So you can use it for contraception if the patient is comfortable. Like I mentioned, like, it just depends on the patient. Is there any specific reason that you want to use it, Clara, for? I'm not sure. I'm not understanding the question, to be honest.
Okay, I've got another question. Can I please ask about instrumental bleeding and whether any new / better options than Norman or Brevinor?
You can always, for intermenstrual bleeding, you can definitely, first, I think it's important to make sure there is no other cause that this patient is having for this intermenstrual bleeding. So definitely maybe look at organizing an ultrasound, because she can be having intermenstrual bleeding because she's got a polyp or because she's got a cervical erosion that probably needs treatment. So that is definitely something that I would do as a first line. But in case of intermenstrual bleeding, we can always look at increasing the estrogen dose, or maybe even adding tranexamic acid to what the patient is in addition to the pill that she's on to help reduce the chances of having intermenstrual bleeding.
That in relation to that, why would you choose Qlara? Why would you choose Qlara over another COCP?
I have no specific preference. If the patient wants to use Qlara, like I mentioned, there is no evidence that shows that one contraceptive pill is better than the other in terms of management of this common menstrual problems that they have. So if the patient it's acceptable to the patient, and the patient is affordable, it's acceptable to the patient, and the patient is happy with the side effect profile of Qlara, I have no specific reason why she should not be on it or not be on it.
Thank you very much, Vidhu. That was a fantastic presentation, and there was a lot of interest in the questions and stuff that come through. So could I just take this opportunity to thank you for taking the time out this evening. For the attendees, please fill out those evaluations and any topics relating to what you've had tonight. Just pop them in there, because we can do another meeting on this. It's obviously a big topic with a lot of interest. So thank you all for attending, and thank you very much, Vidhu.
Thank you.
We'll end the webinar. Bye-bye.
Bye.